Good afternoon, dear patients and dear colleagues. Congenital heart disease is one of the most important causes of children mortality worldwide. With the current talk, I want to demonstrate why it is so important to improve prognosis, and I'm convinced that this is possible. These are the data what we like to demonstrate how congenital heart surgery improved prognosis in congenital heart disease in the last century. Looking to the data from 1940, only 20% survive the significant heart defect, and today, in the year 2000, 5% survive this disease by the very successful surgery like the VT shunt, the follow operation, the atrial switch operation, the Fortan operation, and the arterial switch operation. However, what happens in the last 25 years? These are the data from Germany, and the mortality of congenital heart disease increase starting in 2010. Despite a high number of additional percutaneous intervention and the high number of heart surgeries in Germany, we are the European champion in heart surgeries and percutaneous interventions, and despite the high number of procedures, mortality increase. Looking to the recent US data of mortality and causes of death in patients with congenital heart disease, published in 2025, we realize that patients with congenital heart disease die in infancy, not only from severe congenital heart disease, but also from non-severe congenital heart disease. There's a clear answer on the question why patients with congenital heart disease die. The most important cause of mortality in congenital heart disease is heart failure, and the hazard ratio for heart failure is very high in children, much higher than in the other age group. And the hazard ratio is high not only in patients with complex defects, but also in those with non-complex defects. And the retrospective single center data from Germany from the last 100 years show that the mortality of congenital heart disease decreased, but the reason of mortality is the same. It is heart failure in the first year of life. Looking to the publications about pediatric heart failure in PubMed, there's an increasing number of publications within the last 60 years, starting with digoxin and diuretics in 1962. And we have further publication to digoxin and diuretics today. Finvaxstein was the first who published data about beta blocker therapy in heart failure in 1974, but these publications are not realized in pediatric cardiology. I was the first who published data about beta blocker therapy in infants with heart failure in 1998 and a prospective study in 2000. But the research about beta blockers in pediatric heart failure increased very slowly. In 2007, there is the impression in the US cardiology trial that children with heart failure have no benefit from carbidopa therapy, but this trial include no infants. In 2010, there's a negative result of the US NLP trial in infants with single ventricle. Later, meta-analysis of the data with inodilators show that there's no profit from this therapy in patients with congenital heart disease. And recently, the Panorama trial shows that Entresto, it's the therapy with sacubitril valsartan, have no benefit in children with congenital heart disease. Looking to the current guideline for the treatment of pediatric heart failure, there's a clear recommendation to use diuretics as shown in 1962 in 350 infants, and this therapy is clearly recommended. The dioxin data may be considered based on the retrospective analysis of interstage mortality in infants with single ventricle. If levosimendan and milrinone have no clear benefit in the meta-analysis, it was recommended as bridge to transplant and in a palliative setting. There's a big problem with the recommendation of enalapril that may be considered in infants with congenital heart disease, despite the negative result in 115 infants with single ventricle published in 2010. We have to realize that these infants has a significant poorer head growth in the enalapril treated group compared to the placebo group. Looking to the beta blocker data, we have clearly positive results in more than 100 infants in our CHF Pro-Infant trial and the VSD-PHF trial, but this therapy is not clearly recommended in the guideline. What is the background of this irrational recommendation in the current guideline? These are the single center data from the University Essen, who analyzed the mortality in their department, and the data clearly show that most patients who die in the departments are infants with congenital heart disease. There's a black column with 57 infants who died from congenital heart disease. These are the prospective studies about this issue, and our CHF Pro-Infant study as well as the Indian VSD-PHF study clearly show clinical benefit from this therapy. There are further data from the Gießen approach who used bisoprolol in hypoplastic left heart syndrome. The US enalapril trial from 2010 showed a negative result but was recommended in the guideline. Based on the very high mortality of infants in the US enalapril trial, these patients were excluded in the next prospective randomized studies. And in the older children, there is a negative result in the US carvedilol trial, but there are no infants who are treated with carvedilol in this trial. It's the same situation in the sacubitril valsartan trial. Perhaps there are 6 infants, but there are no infant group in this trial with a negative result. Based on the Essen data, this is the important picture about mortality and therapy in children with pediatric heart failure. 60% of patients who died from heart failure are infants with congenital heart disease, and there's a low number of cardiomyopathies in infants. There are further 20% of older children who die from congenital heart disease, but the number of cardiomyopathies increase in older children. Looking to the therapy, there are convincing data with diuretics, perhaps spironolactone, propranolol, bisoprolol, and digoxin. You should not use enalapril in infants with congenital heart disease. There's a big problem with the therapy in older children if carvedilol, bisoprolol, enalapril, sacubitril/valsartan didn't convince in the prospective trial. Perhaps there are positive results with SGLT2 inhibitors. We have to realize that an effective therapy of heart failure in infancy improves the situation of the older children if the remodeling is prevented by an effective therapy of neurohormonal activation in infancy. We will improve the situation in the older children if we treat effectively infants with heart failure preoperatively. Due to the organ shortage, heart transplantation should be reserved primarily for cardiomyopathies, as no pharmacotherapy has yet proven convincing results in this study. Unfortunately, in Germany, Dietmar Schanz and Gießen and I are the only pediatric cardiologists who further developed the concept of beta blocker therapy in infants with congenital heart disease. Due to my small hospital, I only treat 43 infants with severe heart failure in the last 30 years. But these are the most problematic infants with heart failures. These are the nearly half of the patients have chromosomal anomalies. All patients have pulmonary hypertension, and from this high risk group, 4 patients die that only the patient with Down syndrome and single ventricle. All others survive without heart failure problems in the later life. Based upon this data, each pediatric cardiologist stands for a therapeutic crossway how to treat pediatric heart failure. Should we use the guideline recommendation with diuretics, ACE inhibitors, and vasodilators based on the hemodynamic model of heart failure? You know that these drugs increase neurohormonal activation based on the prospective studies. Or should we use beta blockers who clearly de-escalate neurohormonal activation, who clearly improve heart rate variability, and clearly decrease plasma renin activities, although this therapy was not recommended in the guideline? The most problematic recommendation is the use of vasodilators in infants with circulatory failure due to congenital heart disease. The first publication in the Lancet from 1962 from Alton Goldblatt show that there is peripheral vasodilatation, which normally results in increased cardiac output and venous return, The failing heart cannot adapt to these extra demands, thus the clinical condition is made worse. However, based on the studies in patients with myocardial failure, the guidelines recommend vasodilators. Today, the most recent data show that diastolic blood pressure increasing alleles improve the outcome in congenital heart defects. We have to realize that the recommendation of gallbladder 62 years ago is right. We should not use vasodilators in infants with congenital heart disease. But we urgently should use the monitoring of heart rate variability for risk prediction in infants with congenital heart disease, like shown in our data and the recent data published in Circulation that show that those infants with low heart rate variabilities have the highest risk to die from congenital heart disease due to heart failure. And you should measure blood pressure and heart rate variability in this patient with this device. We use somnotouch in infants by measuring the photoelectrode on the feet instead of the on the toe and feet of the finger. And this is a setting how to measure blood pressure, heart rate, and heart rate variability in an infant with congenital heart disease. The data are very good, and the infants tolerate this measurement without any problem. If you do this, like this measurement of a cardiac decompensation in an infant with atrioventricular septal defect and Down syndrome that was treated with guideline therapy with enalapril, hydrochlorothiazide, and spironolactone, and I see this infant for the first time in a very bad condition with tachypnea and very high NT-BNP levels, high potassium levels, and I admitted him to the hospital and begged to further use the Somnotouch device during intensive care therapy. Looking to these data, heart rate is high, around 150 beats per minute during the first 24 hour of intensive care therapy. The systolic and diastolic blood pressures are low and further decrease in the rescue therapy with milrinone, and the colleagues have to use norepinephrine to stabilize the circulation. They realize that the concept don't work and stop it in the morning. The dramatic situation is clearly shown by heart rate variability analysis, and there's a very low vagus activity measured as high frequency power. There's nearly no high frequency power measured in this baby, and the sympathicus activity measured by low frequency power is even higher. The calling changed the concepts to metoprolol and furosemide therapy. The heart rate decreased to 140 beats per minute. The blood pressure is stable, and the high frequency power that represents vagus activity increase and is sometimes higher than the sympathicus activity measured by low frequency power. And the baby improve very good up to date. Looking to these data in an infant with hypoplastic left heart syndrome after the Norwood procedure with low saturations after Norwood 1 operation with a mean oxygen saturation of 74%, and there are very impressive fluctuation of the diastolic pressure shown in the pink line that seems to be important to stabilize the circulation in this cyanotic situation. The oxygen saturation improve after Norwood stage 2 and further improve in the later situation after Norwood 2 with 6 months of age. And due to the higher oxygen saturation, the fluctuation of the diastolic blood pressure disappear. The baby was treated with metoprolol during the whole time. Metoprolol is the compromise of beta blocker therapy in the patients who are treated by the university hospitals, and these are the data of beta blocker therapy in infants with severe heart failure due to congenital heart disease. There are the high frequency power in healthy infants in gray. Those treated with digoxin diuretics have very low high-frequency powers that clearly improve in the 15 infants who are treated with propranolol digoxin and in the 12 infants who are treated only with propranolol. The 6 infants treated together with the universities who received metoprolol have a better clinical condition, but have further very low high-frequency powers. Beneath the improvement of the clinical condition and heart rate variability with beta blocker therapy, the somatic data on long-term follow-up are very impressive. These are the average data from German patients with congenital heart disease about the head circumferences. Our data of patients who are treated with beta blockers have very low head circumferences that improve with beta blocker therapy in contrast to the patient with severe heart failure who are treated with standard therapy. The same situation is the height. The height remains very low in patients with severe congenital heart defect. Our data show a clear improvement to normal values of beta blocker treated um, uh, infants with congenital heart disease and severe heart failure. And the same situation in the weight, the beta blocker treated infants have in the follow-up a very good weight gain. Why it is so important to improve growth in children with congenital heart disease is shown in this review from 2025. You see that growth failure is related to mortality, to the length of hospital stay, and to the neurodevelopment outcome. This is the reason why growth failure is a big problem in infants with congenital heart disease. If you are further interested in my data, there is a YouTube channel about new approaches in children's medicine, and I show how the mortality developed in children with congenital heart disease in the last years. I show my preoperative therapy of heart failure in infants with congenital heart disease with beta blockers. I show the improvement of catch-up growth in children treated with beta blockers and omega-3 fatty acids. I show how to treat heart failure after surgery of congenital heart disease and the impact of dysautonomia on physical performance in patients with congenital heart disease. Furthermore, the concept of early life stress is very important to understand the growth and neurodevelopmental outcome of children with congenital heart disease. And this is a summary of my new approaches to diagnosis of and therapy of disease in childhood. Thank you for your attention.